Hi, this is Kimberly Dickerson, and today we're going to walk through what the revenue cycle management looks like and explore all that environment. I have my own consulting business. It's healthcare revenue consulting, and I have been dealing with the revenue cycles for 25 plus years. So let's dig down in here. So some of our objectives for today are going to be, what is the revenue cycle? Kind of getting you to know what is involved in the revenue cycle, how some of the negative impacts are on the revenue cycle, both external and those that are internal, as well as positive impacts on the revenue cycle. So the best definition I have found was from the Healthcare Financial Management Association, the HFMA, and they define the revenue cycle as all administrative and clinical functions that contribute to the capture, the management, and collection of patient service revenue. In other words, it is a term that includes the entire life of a patient account from the creation to the payment. In all actuality, it is the financial pulse of that practice. So if you look at the little design here, it is everything. It starts from patient registration, got eligibility and benefits, to data entry, to referrals and authorizations, to coding and billing, to charge posting, claim submission, clearinghouse, payment posting, denial management, secondary filing, if that's part of it. You've done your primary, now you got to do your secondary, accounts receivable, appeal procedures, patient billing and patient collection. That entire piece is the revenue cycle. So let's look at who's all involved here. So the revenue cycle involves everybody. It involves patients. It involves your administrative staff, both on the front end and the back end. It involves your clinical staff. If you have coders on staff, it's going to involve your coders. Your billing staff. Now, your billing staff may include your AR management, but it may not. And who's following that AR management? We'll take a little deeper dive into that later. Your monitoring and your compliance. It also looks at your payers, your contracts, your fee schedules. So it takes all of these people to be involved in your revenue cycle. You can't just look at one piece and expect a fix. You've got to look at each of these. So from the front end process, you've got scheduling. When that patient calls in, it's gonna be key at that point in time that you get some information. You're gonna need to know their name, their date of birth, their address, their phone number, obviously what day works for them. You're also going to capture at that point in time their insurance information. And the reason you capture it at that point is because you want to make sure that they don't need a referral. Are they one that's an HMO that is coming to a specialty practice that they need a referral from their PCP? Do they require pre-certification or pre-authorization? Those can be two different things. They can be the same. Does the service that they're coming for require that? You want to know ahead of time what the patient responsibility is. You want to make sure you notify the patient of what that responsibility is. So you're checking all of that, scheduling, and you got that pre-registration. They can be the same step as far as scheduling getting this information, and then you have somebody doing this insurance verification before they walk in the door. And then you obviously, on that front end process, you have that check-in and that final registration of that patient. Has anything changed since we spoke? You hope not, because you've been through all this other process, but if it has, then you need to take those steps immediately. and look at that. It's key to knowing and helping that revenue cycle. Okay, so from that front end process, and after that, then they go to the clinical staff. So your clinical staff is responsible for making sure they document and capture everything. So they capture all the supplies and all the services they performed. They're documented in there. You're charging for all that. Is the service that you're doing, did we get pre-authorization or pre-certification up front? You know, if you're doing an MRI, 99.9% of carriers want to make sure that that's pre-authorized. A lot of times, physical therapy, occupational therapy, speech therapy require pre-certification or pre-authorization, especially if you get past their benefit period. You need to know and understand what service you're providing, and do I need to get authorization from the carrier prior to performing it so that I get paid. The last thing you want to do is provide a service and you're not going to get paid for it and you can't bill the patient. Because a lot of things, especially if you're dealing with the Medicare age, deals with advanced beneficiary notices. Anthem does this occasionally too, so be careful when you're looking at your Blue Cross Blue Shields or your Humanas. They require that if a service is not going to be covered, that you notify the patients. It may not be called an ABN, which is what that advanced beneficiary notice is, but it's still a requirement that you've notified the patient up front that their service that they're going to be getting or that supply that they're going to be receiving is not covered. So keep that in mind and make sure you understand the carriers that you're dealing with. Your clinical staff has to know that as well. It helps for the front office to kind of make notes on the chart, but that front office or that billing person isn't in the room knowing what's going on with that patient. So you've got to make sure before you give something out or you do some service or supply that may not be covered, that you're notifying these patients, and they have the right to say, I don't want that. And you're documenting that. Then you look at the back, what we call back office or billing. The back office aspect is now you're looking at that charge entry. And depending on a lot of practices, that charge entry actually happens at the clinical side. So your EMRs, they're putting in the services of the charge then. And a lot of times on the back side in the billing anymore, they're reviewing that information and making sure that the documents, everything documented in the note was captured. Those kind of things are going hand in hand anymore. Then you have the claims management. So are claims getting out the door at times, on time? Are they behind? Are we dealing with a practice where the practitioner is not signing off quick enough and that's delaying our reimbursement, which affects our revenue cycle? Our payment posting, are we getting that done timely? Are we looking at denials that we need to appeal? So now we're looking at our denials and appeals, and are those being done timely? The other thing you're looking at is obviously the patient billing. And if patients aren't paying, are you turning that over to collections? That's what kind of goes on back in the back office, behind the scenes. Nobody sees these people, it just magically happens. Okay, so what impacts your revenue cycle? We talked about the different areas. What impacts it? Well, we've all seen decreasing fee schedules. There's been a shift in the carriers that are now doing programs where they're pay for performance plans. That's a lot different than it used to be, where you had a fee schedule, you got paid, didn't matter. Now they're doing pay for performance. We've got a lot of larger deductibles, co-pays and co-insurances. You've got these high deductible plans where A policy may have a $5,000 or $10,000 deductible now that didn't exist 5 years ago. You've got a lot of carriers starting to bundle services and supplies together. Again, you need to know this information. So these are things that are having impacts on your revenue cycle, and I'm sure you can sit here and name a dozen other things. But let's look at some things that are negatively impacting that are external, that this you have no control over. This is what's happening. You've got your decreased fee schedules. Every year we watch as the fee schedules decrease. You've got to figure out how to be more effective with less money. How do I see more patients because I'm being paid less because I still have the same amount of bills because bills are going up? You've got bundling of services. Carriers are starting to bundle things together. How do I get around that? You got non-covered services. When you have non-covered services, again, these are times where you need to make sure that you got those ABNs or that advanced beneficiary notice in place that you can bill the patient, that patients understand that. And now patients really, it used to be physicians driving healthcare. It's not any longer. It's patients driving their own healthcare because they have these high deductible plans, these HSA plans where they have a $5,000 deductible. And you've now said that I need this physical therapy, or I need an MRI, and I'm going to say I want to try physical therapy, or I want to try something else before that because it's cheaper. Or the doctor wants to refer you to XYZ, and the patients come back saying my insurance won't pay for it there. It's cheaper over here, and I want to go there. So patients are being that driving force now. You've got HIPAA. And you may say, HIPAA doesn't have a negative impact. It does. Because now you got to make sure you have everything buttoned down and you have it all secure, and that you are making sure you're auditing and monitoring all that. And that takes time and effort and a lot of money in that aspect. But there are a lot of penalties behind that if you don't comply with that. Got a lot. We're seeing more and more and more of these every year because payers are doing audits. You've got the CERT audits, you've got the RAC audits, you've got the ZPIC audits. And the reason you're seeing more of this is because they're finding errors. And as these groups find errors, they're going to continue to do more and more. If they weren't finding errors and they weren't finding things they could recoup money on, they would go away, but they are. So this is another time, another effort, something you've got to fight, something you've got to make sure your documentation supports. They're having negative impacts on your revenue cycle. And now you've got to figure out, how do I deal with that? How do I make sure that I'm adjusting myself so I don't have those payer audits coming in? Sometimes it's just a luck of a draw. Sometimes it's not. Maybe your documentation isn't up to speed. So we're gonna look at how we can transition that around a little later. So, internally, those were external. You don't have any control to a certain degree over those, but internally you do. So we have poor scheduling. We're not effectively scheduling people on our schedules. How do we get around that? How can we make sure? Are we calling the data before to make sure they're gonna be there? Getting confirmation. We wanna make sure that we're capturing as many people as we can. If your cancellation rate is 40 or 50%, we got a problem. We need to figure out what we need to do. If you've got a large no-show rate, you've got a problem. Do we have a situation where we have a lack of education and training? So let's go back to the scheduling. Somebody calls in to cancel. I'm going to train my scheduler to say, okay, well, that's great. Well, I have another opening on this day at this time. Will that work for you? You want to be that education and training of those positions. Don't assume that it's just a person answering the phone. They don't need to have as much training as somebody in the back. They do. You want to make sure you're capturing all of your revenue. So, and your training. So training is not just the front. I was using that as an example, but you want to make sure, you know, that you're utilizing the education and training, be it clinical staff, be it billing, be it the person doing AR, the person up front, insurance verification. Carriers offer training all the time. You want to make sure you're bicing that. So then you've got another internal impact, as this could be negative, is inconsistent or non-existent. And I don't want to know if it's non-existent, so we want to change that, of monitoring and reporting. You want to monitor stuff. You want to know what's going on. What is the pulse in your office? You want to feel it. You want to know it. You want to be able to make changes as soon as something happens. So do we have ineffective processes? Nobody knows whether a process works or not than the person who's actually doing it on a day-to-day basis. So if you come up with an idea and you put a policy and a procedure in place, you need to circle back with that individual and say, okay, you've been doing it this way for 30 days. Tell me your thoughts on it. How can we do it better? Is it working well? What can work better? They're going to be able to offer those ideas. Don't dismiss them. Say, thank you for your feedback. We'll look at it and go there. It may be something that you're not going to implement, but they may be. So don't discount that they wouldn't have an idea that may make that process even better. Claim denials. If you're getting claim denials, you need to figure out why. Is it now a procedure that's no longer covered, and we need to notify our clinicians that they need to notify patients of this? Is it that we're not providing enough documentation? So now it's an education and training back to our physicians or our practitioners, our athletic trainers, our physical therapists. You gotta provide that constant feedback of what they're seeing on the denials. And patient balance collections. We all should be collecting co-pays up front. That insurance verification is going to tell you if they have a copay, if they have a deductible. If we're in a situation with a high deductible plan, you want to collect that up front. If we don't collect it up front, the chances of us collecting it on the back end decrease substantially. And you want to make sure you're staying on top of that. And you need to have a policy in place that says if they don't pay it in so much time, it gets sent to a collection agency. You have incorrect payment posting. If your payment posters aren't paying attention and they're just posting and, oh, I'm just trying to get this done, are they posting correctly? You need to be doing audits. We want to make sure that we're identifying if we have a mismatch in the fee schedule. If I'm supposed to be paid $50 for this CPT code, I want to make sure I'm getting paid $50. If I'm not, then I need to be contacting that carrier as to why. And if the fee schedule has changed, you need to know that. And maybe now that's a chance you go back and try to renegotiate it or figure out what's going on. So now let's look at changing these negatives that we just discussed to positives. Are we in network or are we out of network? If you're a large practice, is part of the clinicians in network and the other part are not. You need to know that. You need to know where you need to schedule them. Again, is a referral needed from a PCP? I need to know this, because if I don't get a referral from the PCP, a lot of times I'm not going to be able to bill that patient either, because I didn't do what I was supposed to do. And they're going to deny it, saying patient's not responsible. Now, again, you want to make sure you're going through these things. Is prior authorization needed? I need to get that ahead of time. Carriers are more and more not retroacting authorizations. They're saying, has this service already been done when you call in? And if you say yes, they're saying, I'm sorry, I can't do anything for you. So you need to make sure you know ahead of time if this information needs to be done. Again, you need to notify patients of their responsibilities, especially those patients who are going to have a large amount out of their pocket. They need to understand that, yes, they're just coming in for what they think is an easy office visit, but it's all going to their deductible, and they're going to owe this large amount that they're not even thinking, because patients don't understand the cost of what it takes for medical practitioners to exist. And you need to have a cancellation policy. It needs to be in writing. It needs to be visible to your patients, and they need to acknowledge it. So you need to have, on their first visit, them sign that they understand the cancellation policy. It needs to be, you know, whether it's $25 if you don't cancel within the last 24 hours, or it's $50. If your appointment slots are an hour, maybe you're charging $50 for that cancellation. You can charge whatever you want to the patient as long as they have it ahead of time and they're notified of that and they understand that. Okay, so again, we start looking at these things prior to the appointment. You want to make sure you're doing insurance verification. Don't only do it on new patients. Please do it on everybody. Those established patients may have changed insurance. So just because they say, oh, yeah, I was here last month, and it's the same. Make sure you're running it, because maybe, just maybe, they changed and it's just a group change, but it's a new card. It means a new deductible, their policy year changed. You need to make sure you're asking that at each visit. You need to be checking that. Again, pre-certification, pre-authorizations, making sure you're obtaining those. Okay, we're looking at those referrals, making sure we have all those in place prior to the appointment. And we're notifying those patients of what their responsibility is going to be. This is all happening prior to the appointment. And then we get into what kind of changes can we make that have an impact at the appointment. We double check patient demographic information. We make sure we haven't transposed a number. We have the correct date of birth. We have the correct individual who is the insured on the policy. Remember, the patient and the insured may be different individuals. So you want to make sure that you are collecting both of that information. You want to make sure that you're collecting copays. If there's a copay for that visit, you need to collect it. If they have a patient balance, you need to be looking at that balance on their account. If for some reason something went to their deductible that we didn't know about, and we've got a balance on their account, you need to be trying to collect that at their visit. So these are all changes that can have a positive impact when they walk in the door. Okay, so that's at the front. So now we look at, they're back with the clinical staff. Again, we need to make sure we're capturing all the supplies, all of the services. If we've done an EKG in the office, we need to make sure we're capturing that it's being documented in the note. Everything you do needs to be documented in that note. We need to be capturing that information. We need to make sure that with our clinical staff that somebody's providing education for them regarding services that require pre-authorization and pre-certification. So if they're in the office and they want to do something else, they know, does that fall on this list that I need to do pre-authorization first? Is it something that I can just go ahead and do? Or is this something that's not covered by the carrier and I need to get an ABN for? And then make sure that we're completing those ABNs. The one thing everybody needs to understand is ABNs have to be completed prior to them receiving the supply or the service. What I've seen a lot of practices try to do, and what you can't do, is, oh crap, the patient just left and I forgot to have them sign an ABN. I'm going to mail it to them and have it sign them and mail it back in. You can't do that. It has to be completed prior to any service or supply being given. The patient on those advanced beneficiary notices has the right to say, I understand it may not be covered. I want you to go ahead and try to bill it. Or, I understand it won't be covered, but I still want it. Or, I understand it's not covered and I don't want it. So they have to make that choice. They need to sign off on that. All right, so now we start looking at some stuff from the back end. We've got the front office doing a great job. They're verifying insurance. We're making sure authorizations are in place. They're collecting any copays or any deductibles up front. And now we're starting to look at we got the clinicians who have captured everything. They're documented for everything, ABNs if necessary, and now we're in the back office. So now we start looking at coding. This could be like that middle point where the clinicians are coding some of it, and you are now looking at or you have a coder who's doing it. So it could be part of the back office or part of the clinical staff. But you want to make sure that your diagnosis codes are specific. ICD-10 now drops in lots of options, and you want to make sure you're being as specific as possible, getting down to the specific side. And exactly, if you have left knee pain, you want to make sure you're coding left knee pain. If it's a left meniscus tear, you want to make sure that's what's coded. You want to be as specific as possible. And you want to make sure you're doing that in the correct order. And so you want the most specific and the main reason first, and then you have other stuff. So you want to make sure those are in the correct order. The CPT codes. You want to make sure the codes are bundled together if they're supposed to be. So if a certain CPT code includes something else, you want to make sure that's correct. Or if it doesn't, you want to make sure you have the appropriate modifiers on it. And again, when you're looking, there are modifiers that are required for different things, whether it's anesthesiology or it's physical or occupational therapy, there are certain modifiers that are required. Or if, for whatever reason, there isn't a specific code, and I would say there probably is, but for right or left, you want to make sure you're putting an RT or an LT on it. And you want to look at the charge entry, making sure that the demographics are complete, make sure we have the correct insurance information, making sure charges are all in there. This is something you can do that we're trying to make sure before it even goes out the door that we have everything correct. And doing insurance verification will ensure that we have the most accurate information. Claims management. You want to make sure you are monitoring all dates of service. Do we have an unbilled claims report? So why are they unbilled? Is it because the provider hasn't completed their documentation yet? I want to know that. You know, we want to make sure that those notes are getting done in a timely fashion. And we want to make sure we're getting this documentation submitted to the claims out the door quickly so that that money can come back to us. Most of the time we're submitting claims anymore electronically. So we're going to make sure, was it accepted by the carrier? There's reports for that. I'm going to be reviewing those reports. If it didn't get to the carrier, why? Was their policy termed and I didn't know about it? That means we didn't do a very good job on the front end of insurance verification. Or maybe it was a situation where the time we did the insurance verification on March 31st and they showed up on April 3rd, that they had changed insurances and they didn't tell us. It happens, but we need to catch it as quickly as possible. What we don't want, if we're not reviewing those, is that now it waits till we're down looking at our AR and wondering why it hadn't been paid, and we're calling on it, and we're 30 to 45 days out now. And oh, we got the wrong carrier, or we had the wrong ID number. So we want to catch those as quick as possible. We want to make sure that in payment posting, that our fee schedule that we have with this carrier is what we received. So your practice managers need to make sure they're sharing those fee schedules with the person posting those payments. They need to understand that Blue Cross is supposed to pay us this. And that payment is a combination of the patient responsibility as well as what we actually receive from the carrier. So we want to make sure that we're getting the full payment. So if the patient owes me a $20 copay and my charge that I was supposed to be paid was $50, then I need to be making sure I'm getting an insurance payment for $30. If there's a discrepancy, we need to be going back to the carrier and finding out why. We need to look at our contractual adjustments. In payment posting, we do have contractual adjustments. If I charge $100 and the fee schedule that I've agreed to is $50, then I'm going to write off that other $50. My payment poster should be adjusting those off. I don't want that money sitting on my AR so that it looks like it is higher than it should be. So you got to make sure things are getting posted correctly. If it's bundled by the carrier, should it have been? If it shouldn't have been, we need to be doing a denial. Did I get a partial payment? Did they split the claim, and why? And denials. When you're posting a payment, you need to make sure they're putting specific denials if it was denied, so that when you start appealing or going after those denials, you know exactly what you're appealing. Is it because it was bundled and it shouldn't have been? I want to know it was bundled. Is it because they denied it as non-covered and you know it's a covered benefit, so why did they say it was non-covered? You need to know what those specific denials are for. Is it because they denied it because it was past the timely filing? That's really going to hurt your revenue cycle, because that means you're going to be writing it off. And you need to make sure you're tracking that. So if we have the appropriate remark code on there, or transaction code, we'll know how many we were denied and that we had to write off because it was past the timely filing. And then we got to figure out how to change and educate to get around that. Okay, so then we look at our denials and appeals. Our payment posters have done great. They put the correct codes on there. I know who I need to go at and for why. Then we need to start tracking and monitoring if we have a problem. Have all of a sudden I started getting 50,000 denials for non-covered from Blue Cross, and now I've been tracking it, so for this CPT code, it's all of a sudden no longer covered. I'm going to make a phone call. I want to know that. I see a trend. Is this something I need to go back and educate the clinical staff to say, we need an ABN, this is no longer covered? Did they change their policy? Do I need to go pull a policy from the carrier? Carriers have policies and procedures out there themselves, medical policies. Go out and look for their medical policy on that. Did it change? Did it just get updated? We need to know this. We need to make sure we're staying on top of those for those areas that we provide. Did I use the wrong CPT code? Did I use the wrong diagnosis code? Did it mismatch? Did I provide a code that indicated female and it's a male? We need to make sure we're tracking all of this. Was it due to an internal error? That we didn't have the right eligibility, we didn't get our authorization? Or we're just using invalid codes. We haven't updated. ICD-10 updates every year in October. It's not at the first of the year. So 2020 codes for ICD-10 started October of 2019. Was that code deleted and now you have a new code? You need to make sure you're using the most current codes. Do we have payer issues? Are there policy limitations that we didn't know about that have changed? They used to cover for 20 visits. Now they're only covering for 12. Was that a policy change? Again, looking at those medical policies, you're going to know that. Are they inappropriately bundling the payments? Are we looking at a coordination of benefit? So they had Blue Cross, but actually their primary was Aetna. So we sent it to the wrong one to begin with. All things that we need to be tracking and looking at when you're looking at those denials on the back end. Because is there a training that we need to do? Again, education and training. Knowledge empowers you. That is the key. You need to know this. You need to be looking at it. You need to be training on this. You need to look at the data entry errors. How many of those are we having? Do we need to go back and talk to our data entry people at the very front when they're scheduling the patients? Did we not revalue that when they walked in the door to make sure that we had it appropriate? Are we just being quick and lazy? All things we need to look at. Again, coding. Are we getting the proper CPT changes on there? Are we doing the right diagnosis codes in the right order? For that CPT code, they're going to cover this diagnosis, but if we put that diagnosis in the second order and the first one is one they're not covering, they're not going to cover that. Making sure it's in the proper order. Looking, does it require a modifier? If you have an office visit and you're doing a procedure in the same day, you're going to have a modifier or you're not going to get paid for both. Has the policy changed? Has they changed what they define at the carrier level in medical necessity? What's going to meet their medical necessity? That they requires that they have 6 months of conservative treatment? We need to know that. Did it go from, it was 6 weeks, now it's 6 months? the big difference. We need to be monitoring those changes. Is it just no longer covered? Those are all items that we need to continue to review and train on as we see something different. Successful doing this, everybody working together like a puzzle will have a successful impact on your revenue cycle. It will help bring that money in and keep you functioning daily as we deal with changes that are out of our control. We can't control whether a payer decides they're going to run a random audit, but we can control certain things, and we need to just work on those items. Again, the next slide, I'm going to provide you my information. If you have any questions, please feel free to email me. I'm here, and I'm willing to help you in any way I can. Thank you.